Welcome to the first session of Mini Medical School, the hidden world within the gut microbiome. My name is Levi Teigen. I'm an assistant professor in clinical nutrition in the Department of Food Science and Nutrition at the University of Minnesota. In addition to my teaching, I lead a research lab primarily focused on advancing medical nutrition therapy. We study how microbiome-targeted diet strategies can be used to help manage disease, but we also study how diet and the gut microbiome impact long-term health and wellness. We're excited to have you here today. The first topic in the series explores what is gut health and why does it matter. We'll begin with a moderated discussion, followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box. This can be found by clicking on the Q&A button at the bottom of your screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. Today we have the privilege of speaking with a panel of leading experts who will introduce the anatomy and physiology of the digestive system, common gastrointestinal conditions, and how gut health connects to systems throughout the body. Now I'd like to introduce our first panelist, Dr. Joshua Sloan. Dr. Sloan is an associate professor in the Division of Gastroenterology, Hepatology, and Nutrition. He's also the director of the Esophageal Disorders Program, director of the Luminal Section, and director of endoscopy. Dr. Sloan, can you introduce the upper gastrointestinal tract, in particular, the role of the esophagus?
Hi, Levi, or Dr. Teigen. Thank you for the introduction. I'm going to share my screen here. And hopefully that is looking good for everyone.
Yes, looks good.
Perfect. All right. Well, hello, everyone. Thanks for jumping on and listening in. As mentioned, my name is Josh Sloan. I'm an adult gastroenterologist here at the University of Minnesota, and I do esophagus. So that's what we're going to talk about. And I'm going to touch on a couple other things, but arguably the esophagus is the most important organ in the GI tract because without it, you have a tough time getting food in. So with that, I'll get started. And we'll start with this little comic here, and I have it here as kind of a joke, but at the same time, when things don't go right, you have problems, right? So if the oropharyngeal or the swallow function isn't working properly, you can end up aspirating, which has some downstream implications, hospitalizations, and antibiotics from aspiration pneumonia, and so on. So it's a very important and complicated portion to the introduction to the GI tract. These are my disclosures. And so the objectives for me today, I'm going to introduce swallow function and touch on some anatomy as well as some nervous system stuff, but we're not going to dive too deep into that. I'm going to introduce the stomach only a little bit because it is important, but the esophagus is way cooler. And we're going to talk about some pathology. What diseases impact us as human beings? Because when things don't go wrong, we have symptoms and we need to figure out what is happening. I'm going to be covering a lot of topics, so I apologize in advance for speaking quickly, but hopefully we can hit on everything and all learn something today. So we're going to start with the oropharyngeal swallow. That's the initiation of the swallow. So you have muscles up in your head and neck area. And so the levator veli palatine muscle will contract, and this is going to cause or result in soft palate elevation. You're going to generate pressures that are going to help get that bolus of food down to where it's supposed to go. The tongue base is going to push against the back wall, and that's also going to provide some propulsive pressure. And then ultimately, you have upper esophageal sphincter relaxation, and food should get into the proximal or the top part of the esophagus and onward on its journey. Now, when things aren't working correctly with the oropharyngeal swallow, we're typically thinking of things that are central nervous system mediated, right? You're not able to swallow correctly, or thinking of patients who have had head and neck cancers and radiation and surgery that impacts the ability to swallow. And sometimes symptoms might be nasal regurgitation, stuff not going down, but rather going back up. Now, once we get into the esophagus, we have inner circular and outer longitudinal muscles. The upper third or the proximal third of the esophagus is skeletal muscle. The lower 50% or distal 50% is smooth muscle. And then in the transition zone, that is mixed with skeletal and smooth muscle. Now, I'm not going to belabor the point of the innervation here in the esophagus. I'm really showing this to highlight how complicated things are. Suffice it to say, everything is vaguely mediated, right? And so when there is a problem with the vagus nerve, this can impact the ability of the esophagus to function, both from that initiation of swallow as well as that smooth muscle contraction pattern where things may not work correctly, again, driving symptoms because of a motility process. Now, once that food gets through the esophagus, it's going to pass through the lower esophageal sphincter, and I have a slide coming up on that where I'm going to talk a little bit more about the kind of the function of the high pressure zone, which the lower esophageal sphincter is a part of. But you get into the stomach, which can be broken down into different areas. You have the fundus, you have the body or corpus, you have the antrum, and then the pylorus and the pyloric sphincter. Now, when you think about it in functional regions, you have the proximal stomach, you have the pacemaker region, distal stomach, and again, the pyloric sphincter. Now, what is the function of the stomach, right? So first off, you want to have gastric accommodation. So the stomach needs to relax to accommodate the food bolus that's getting in there. If that doesn't happen properly, oftentimes patients will have symptoms such as nausea, vomiting, or gastroparesis-like symptoms. We're not going to talk about gastroparesis, but again, that is a component of gastric dysmotility. The stomach also begins the process of breaking down food, right? You've chewed your food, but then the stomach is going to mechanically push that food with a contraction wave against the antrum, further breaking it down. And this is again mediated by the vagus nerve and the interstitial cells of Cajal. Basically, these cells that are generating this the impulse to create this contraction pattern. And then lastly, acid production. This helps break down food. It converts enzymes to an active form, and arguably is also involved in maintaining gut health from the microbiome perspective. Now, I know some of you out there are thinking, well, I'm on acid suppression medications. Fortunately, the human body is still capable of having a healthy environment, even if one is on acid suppression medication. I'm not going to dive into that conversation. Suffice it to say, that is a talk in and of itself, but the benefits usually outweigh the risks. So dysphagia, what is dysphagia? This is the sensation of food getting stuck or going slowly through the esophagus. This is not normal, right? Normally, you should swallow and food gets from A to B. From a GI perspective and from a human perspective, this is an alarm symptom, right? This requires endoscopic evaluation. So if you're out there and you're listening in and you say, yeah, I have trouble swallowing, talk to your provider, right? Because you probably should have an endoscopy to evaluate, assuming that you've not had that to date. Why do we want to do that? What are the things that we're looking for there? I'm going to go through that. But again, the big concerning thing is you want to make sure that there isn't a malignancy. You don't want to have a cancer that is growing and contributing to these symptoms. We want to evaluate that. There are other anatomic findings that we can potentially see and treat. Now begins a little bit of show and tell. So this is an endoscopic picture of the esophagus, right? So this is a normal looking esophagus from the upper or mid portion looking down. You see nice normal tissue. You see a nice vascular pattern. As we perform an endoscopy or that food bolus is going down, you get down to the lower part of the esophagus or the distal esophagus. And then this is the EG junction or the esophagogastric junction. So this is where the esophagus transitions into the stomach. This is a normal picture of the gastric body or the stomach, right? You're looking in, it looks nice and healthy. It doesn't look overly red or irritated. This is the incisura. Again, thinking back to that slide with the anatomic diagram, that's that bend or the angle of the stomach. And this is highlighting the antrum and the pylorus. Now, I'm not going to dive into the small intestine or the duodenum, although arguably that is in part the foregut. I know Dr. Howard is going to touch on that briefly as well. So, getting back to dysphagia and thinking about the different etiologies, right? We have benign causes of dysphagia and we have malignant causes of dysphagia. So, GERD is a very prevalent condition, gastroesophageal reflux disease. And while dysphagia historically isn't a typical symptom of reflux disease, certainly it can be a part of it, specifically in patients who perhaps have erosive esophagitis. The esophagus is irritated or aggravated because of acid injuring the esophagus. Um, or if someone has a peptic stricture, a consequence or narrowing because of that chronic reflux. Motility abnormalities can cause dysphagia. Eosinophilic esophagitis is another condition that can cause dysphagia. And sometimes, despite going through a number of different studies from the esophagus standpoint, sometimes everything comes back normal. And then we start talking about functional dysphagia, which we're not really going to spend much time on, but we treat that differently. It's not to say that someone isn't experiencing the symptom, but we're just not seeing an objective reason for that symptom. Now, getting into the malignant side of things, esophageal squamous cell carcinoma and esophageal adenocarcinoma. And there are certain risk factors for that, which I'm not necessarily going to dive into, although I am going to touch on Barrett's esophagus, which is a risk factor for esophageal adenocarcinoma. Now, this is just a picture from a paper a long time ago where essentially we're looking at that high pressure zone of the lower esophageal sphincter or the lower esophagus, really. And why is this important? Because this plays a role in reflux disease. As well as some motility abnormalities. But you can see in these images, there's an endoscopic ultrasound, and it's highlighting that that high pressure zone is made up of both the lower esophageal sphincter, but also when it's in line with the diaphragm, right? That's providing a pressure to that area, as well as certain fibers from the gastrocardia or the top of the stomach, which is the sling and clasp fibers. And all of these components help to prevent reflux disease. When things are out of line, that's one reason why someone could have reflux. And so this is an example, right? So this is a 10-centimeter hiatal hernia. And what is a hiatal hernia? That's when the stomach is above the diaphragm, right? And so you can imagine that that's going to allow for more reflux into the esophagus. And again, from a number of different reasons that we don't have time to get into. But speaking specifically about that high pressure zone, now things are just not lining up, and that's going to allow for more reflux. So let's talk about reflux in greater detail. Actionable GERD, that's what we're thinking about. Conclusive evidence is what we want to look for, and that's endoscopically, pH testing, which I'm going to touch on, and it should be in the presence of troublesome symptoms. And those symptoms are going to be heartburn, regurgitation, and chest pain. And I want to throw out a caveat that if you are someone who has chest pain, you should be seeing your primary or your cardiologist first before you're seeing a gastroenterologist. If you haven't, we're going to send you there because obviously a cardiac event is a much more acute thing. Once that is ruled out, then we're going to explore reflux as a cause. Atypical symptoms include belching, chronic cough, asthma, hoarseness, globus, nausea, abdominal pain, and bloating. Now, this is a picture of endoscopic LA grade A esophagitis, some inflammation to the lower part of the esophagus. I don't know if you can see my mouse cursor here, but that's highlighting right at that kind of top of the image there. Now, LA grade B, C, and D is going to be evidence for pathologic reflux. That is evidence that you have gastroesophageal reflux disease. And in this case, you can see that it's extending beyond 5 millimeters and not crossing any mucosal folds. Now, LA grade C looks a lot angrier, right? So this is encompassing over mucosal folds, but less than 75% of that circumference. And then LA grade D, that's the angriest of the LA grades when we talk about erosive esophagitis, and that's greater than 75% of the circumference. But when you end up getting your endoscopy for symptoms, most of the time it's normal, right? That can be frustrating from a patient perspective because you're expecting someone to find something, but you're in good company because most people have a normal endoscopy. So then we can pursue things like pH testing. This is an example of a wireless pH test where we pin a device to the lower part of the esophagus and we're looking for that acid exposure time over a 4-day period. So that's one way that we can measure reflux. This is a 24-hour pH impedance study. So I have two fantastic esophageal motility nurses that will perform manometry and pH testing, and there's a 24-hour catheter that goes down into the stomach. And you can see here in this red area, this is acid exposure, so the pH is less than 4, and then utilizing impedance technology, which think back to physics or talk to an electrician. Basically, it's the resistance of flow of electricity, and you can see visual representation of that liquid going up the esophagus there. So what are the consequences of reflux disease? As I mentioned, peptic strictures, they can be a problem. This is narrowing in the lower part of the esophagus. It's evidence of significant reflux and oftentimes needs to be dilated because food gets stuck. Barrett's esophagus. This is a precancerous change to the lining of the esophagus that has, again, a risk of progression to cancer. So it's something that we want to be mindful of. And then lastly is malignancy, which is either coming from Barrett's esophagus or arising without any prior history of Barrett's esophagus. Now, just to touch on Barrett's esophagus, we measure this based on the length, both in terms of circumference as well as the maximal extent. And so if you have an endoscopy or you have a history of Barrett's, that's what that C whatever, M whatever is. And this is an example here endoscopically of someone who has C3M4. So that's circumferential 3 centimeters of Barrett's and maximal extent is 4 centimeters. On the right side is that normal light of the endoscopy. On the right side is the narrow band imaging, which is a filter on the scope that allows us to highlight the tissue differently. So I do want to talk about the importance of thinking about your symptoms, right? So this is a case where an individual had an anti-reflux procedure, so Nissen fundoplication, and they started having symptoms of reflux again, right? So their symptoms were controlled following a surgery for reflux, and the symptoms recurred. They ended up getting a manometry, so catheter through the nose to test the function of the esophagus, and there was this finding called inconclusive esophagogastric junction outflow obstruction, which is something that we see often in the setting of prior RAPS or surgical intervention. Now, the most important thing was that the endoscopy that we performed showed, okay, the wrap is no longer tight around that the scope, and you'll just have to take my word on that. But then when you look in the forward-facing view from the esophagus, that tissue doesn't look normal, right? And so biopsies showed that there was cancer. And so again, this, I think, brings home the point that if you have symptoms and they were previously controlled, talk to your provider, right? Because you shouldn't just sit back and say, well, it's already been treated. You should undergo further evaluation. So I'm going to switch gears to benign esophageal condition called eosinophilic esophagitis. And based on time here, it's a chronic inflammatory immune-mediated process that is occurring because of whether it's food antigens or allergens in the environment. But it's a clinical pathologic diagnosis where you talk to your provider, we get a history, we do an endoscopy, and we get biopsies, and we put it all together. And hopefully you remember back to that nice normal esophagus and compare that to this, where you see hopefully a narrow caliber here. You see rings, you see furrows, you see some whitish stuff. So those are exudates. And this is consistent with eosinophilic esophagitis. And this is the consequence, right? Difficulty swallowing. And this is what happens when there's a food impaction. And oftentimes that's the middle of the night, and you don't want to have that happen to you. This is an example of normal peristalsis, switching gears to motility. So this is just trust me, a normal swallow. This purple haze is that impedance technology again. This is how it should look when we do a manometry. This is utilizing functional lumen imaging probe, so another way to assess that motility. This is normal repetitive anterograde contractions. That's the normal pattern that we want to see with normal relaxation of the lower esophageal sphincter. Now, this is an example of hypercontractile esophagus. Hopefully you can appreciate, even without any training, that this looks like a really strong contraction compared to that other normal peristaltic image I showed before. And so again, we do these things because of symptoms so that we can try to identify what's going on and hopefully try to fix it. With that, I'm going to leave you with a picture of a food bolus and a food impaction again. So if you have difficulty swallowing, if you have reflux disease that's not been investigated, please talk to your providers, get it evaluated, because otherwise things can go wrong, and we want to prevent that. So thank you very much. Incidentally, at the bottom here, Globus, that was a restaurant in Switzerland. I don't know if it's still there, but Globus is the sensation that food is sitting in your esophagus. So thank you again for listening in.
All right. Well, thank you, Dr. Sloan. As a reminder to everyone, please continue to submit your questions using the Q&A box. Our panelists will answer them after all presentations are complete. Now I would like to introduce Dr. Justin Howard. Dr. Howard is an associate professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition. His research interests include treating patients with inflammatory bowel disease, also known as IBD. Dr. Howard, can you introduce the lower gastrointestinal tract and discuss IBD?
Thank you, Dr. Teigen. Yes, I'd be happy to talk about that. Just sharing my screen here. All right. Whoa. Can everybody see that?
Yes, looks good.
All right. So we're going to talk about the lower GI tract today, and we're going to pick up right where Dr. Sloan took off. Here's my disclosures. I have none. And just going to talk about some of the objectives here. So we're going to do a little bit of an overview of the GI tract in general, and then we're going to talk about specifically what makes up the lower GI tract. It's not as complicated as you may think. And then we're going to talk about what is the purpose of the lower GI tract. And then we're going to talk about some examples of what can go wrong and talk a little bit about lactose intolerance, celiac disease, and inflammatory bowel disease, or IBD for short. And in talking about these things, it'll give us a little more insight into what the lower GI tract does. So again, here we have the digestive system. This is kind of a fun schematic of the digestive system. As Dr. Sloan outlined, food goes in your mouth, down through the very important esophagus, into the stomach, where you start mechanical digestion, and then it goes into the small intestine, where we'll talk about what happens in the small intestine, and then into the large intestine, or another term for that is the colon. And then the waste that's left comes out the anus when you go to the bathroom. All of these things are very important. So what makes up the lower GI tract? Here we have another schematic kind of talking about, you have the stomach and then you have the small intestine, and there's three parts to the small intestine: the duodenum, then the jejunum, and then the ileum. Those make up the small intestine. And then you have, after that, the large intestine, or the colon. And each of the duodenum, the jejunum, and the ileum have a little bit different and very important function. Now, what makes up the lower GI tract? The reason I have this. So you have the duodenojejunal flexure, or the separation between the duodenum and the jejunum. And technically, anything above that flexure is the upper GI tract, and anything below that is the lower GI tract. So the jejunum, the ileum, and the colon are all the lower GI tract. But for the purposes of our, a lot of things, some of that's more historical, and specifically what we use to talk about GI bleeding. In the real world, the duodenum, the jejunum, the ileum all, kind of work together to do the function of the small intestine. The next picture here is just a closer view of that duodenal-jejunal flexure. There's a little ligament called the ligament of Treitz, and this separates the duodenum from the jejunum. And now, if you like trivia games, this may come up. That's really the main point of it. But the ligament of Treitz is what separates the upper GI tract from the lower GI tract. So what is the purpose of the lower GI tract? And really, the purpose of the lower GI tract is to continue to really start the digestion of the food, break it down so it gets to a point where later in the small intestine, it can be absorbed. So you can absorb those nutrients, the body can use that for energy and to maintain the body's functions. And we're going to talk a little bit more about that here. So on the left portion of this table, we have the duodenum, the jejunum, and the ileum, and the colon. Again, the duodenum, the jejunum, the ileum make up the small intestine, and then the colon is the large intestine. So first, that food leaves the stomach. Remember, like what we talked about, the stomach is kind of like this big mixing thing. Really, the main purpose of the stomach is to break food down into small enough pieces so the food's in small pieces and it increases the surface area so that as it goes into the small intestine, the chemicals, the digestive juices that come from the pancreas and the bile that comes from the liver can work on that broken down food and then digest all those things into smaller and smaller pieces, and then they can be absorbed up. The stomach does a little bit, it has the acid, like Dr. Sloan talked about, to break things down, and a little bit of enzyme digestion, but really most of the actual chemical digestion starts in the duodenum. And in addition to the pancreatic juices and the bile being entered in there, it also has these Brunner glands that secrete an alkaline mucus that work together with the pancreatic juices to help neutralize the acidic contents that are coming in from the stomach. And in the duodenum, you get most of your absorption of your iron, your calcium, your folate, starts your water-soluble vitamins, and it begins to break down that carbohydrate and protein digestion. It's very important to break down these carbohydrates, these sugars, and these proteins because your small intestine needs them to be down into these small molecules, these single, what we call monosaccharides, in order for it to be absorbed effectively. If it can't do that, we'll talk about that a little later, that's when you get into some problems and some symptoms. As things go further down, remember, as they leave the duodenum, they go down into the jejunum, the second portion of the small intestine. And this is really where most of our nutrients are absorbed. And you get the sugars continue to be absorbed, the amino acids, the fatty acids, your fat-soluble vitamins, all of these really get to be absorbed. And in order to make that happen, the jejunum has really tall and long villi. Now, you probably have heard about villi, but villi are these, and you can see in that picture over on the right side of the screen, that's a healthy appearing small intestine. These villi are these finger-like projections, and that helps increase the surface area and helps surface area for absorption. And we're going to look at those a little more here as we move along. And as the food or the chyme, the material in your small intestine is called chyme. As that moves along, we get into the ileum, and this is really where most of the remaining parts of your nutrients are absorbed. And specifically, like your things like vitamin B12 is absorbed there. Your bile salts. So bile salts are part of the bile that are secreted by your liver. And the bile helps your body to be able to digest and absorb fats. And as you get down to the small intestine, the ileum reabsorbs those bile salts so then it can go back to the liver and use them again. It's like recycling. It's really, really great. And the ileum has special receptors to do that and to absorb your vitamin B12. If you lose your ileum, then you can have trouble with that. And that can cause symptoms like vitamin B12 deficiency. It can cause bile salt-induced diarrhea and other issues. And then as that chyme enters into the colon, Remember, chyme is what we call the contents of the small intestine. As that chyme enters into the colon, the main function of your colon is to reabsorb water and electrolytes. And in addition to this, it really turns that chyme into stool, or the poop that we see that comes out into the toilet. And it does that by absorbing the water and making it more solid. And then also, this is where most of the bacteria in our GI tract are. And that bacteria works and ferments things and helps turn it into the stool. Like I already said, it absorbs where you get a lot of your water absorption and some electrolyte absorption. But then any residual like vitamin B12 gets reabsorbed there. So as we move on, we're going to talk a little bit more about the anatomy and histology. I'll just remind you that on the right side of the screen, you have a normal appearing small intestine, and then below that, you have a normal appearing colon. You'll see the villi on the top for the small intestine, and there's no villi on the bottom for the colon. So we're going to kind of dive a little bit more into the cells of the small intestine here. So you can see on the left side of the schematic, you have just the small intestine, kind of the gross piece of that, like if a surgeon were to chop that out. Then if you were to look at the fold, you see there in the middle on the left, you see that a schematic of the fingers of the villi, and that helps increase the surface area. And then on top of that, each of those villi have smaller little enterocytes, and on those enterocytes, they have what are called microvilli, which increase the surface area even more. And really help the small intestine really absorb things super good. Here you have a histologic sample. So this is actually a microscopic sample of the small intestine. And you can again see those finger projections. It's really quite beautiful. And then here's another schematic, just a drawing, and you can see this is those villi again. And then inside those villi, you can see in close proximity, this is how our body in close proximity gets you have the capillaries going up in there, and you get the blood supply in close proximity to those enterocytes, to the cells of the small intestine. And so you can get those nutrients, go right across those single cells, right into the bloodstream, and get into the body for the body to use them. It's really amazing. It's amazing how it works. And then this is just another schematic of those cells. Again, this is the single cells of the enterocyte or the cell of the small intestine. And you can see on the top there, it has those microvilli, really increasing the surface area, and it absorbs those nutrients that have been broken down in the small intestine, and then it gets those into the bloodstream so it can be used. This, if you could remember, so remember back to we talked about the small intestine, this is a picture of the colon. The colon does not have those villi. So remember the villi in the small intestine with those finger-like projections, and here we have the colon, which is really, you look at the top surface, it's flat because it doesn't need those. It's not where the body absorbs all the sugars, all the amino acids, and the fatty acids. This is mainly used for absorbing water and electrolytes. It doesn't need those finger-like projections. So there, now we are all been introduced to the functions of the small intestine and the colon and how it's supposed to work. But what happens when things go wrong? Well, when things go wrong, we can get symptoms. And we're going to look at some specific examples here. So I think a lot of people are very familiar with lactose intolerance. But what does that mean? So like we talked about, on the left side, you see what happens normally. So this is schematic. The top part is the small intestine. The lower part is the large intestine or the colon. When you eat something that has lactose in it, what normally happens is that lactose goes down into the small intestine, and our bodies contain lactase. Now, lactase is the enzyme that breaks down lactose, and it breaks it down into glucose and galactose, and those are the monosaccharides. Remember when I said in order for our intestines to absorb these sugars, they have to be broken down into these monosaccharides, like the glucose and the galactose. And so if we have the lactase enzyme in there, then the small intestine can readily absorb those glucose and galactose in through those enterocytes, and things go great. You get the nutrients, you don't have any symptoms from it. But if you are lactose intolerant, meaning you don't have enough lactase in there, then that lactose just goes shooting down that small intestine and it doesn't get absorbed. And in addition, it pulls liquid and extra liquid from the small intestine walls into the lumen or into the GI tract. And when the lactose gets to the colon, where there's bacteria there, we said the small intestine, when there's no lactase, our GI tract can't digest the lactose, but when it gets to the colon, the bacteria can digest it. The bacteria can use it, but it does it inefficiently and it ferments it. And as part of that digestion process, then you get the resulting gas and acids that then will lead to flatulence, which is extra gas. You get this gas pains, you get this bloating, and you get diarrhea. So that's how it happens. You can't digest the lactose, goes down into the colon, the bacteria breaks it down inefficiently into like methane gas, hydrogen gas, causes bloating and diarrhea. I did also want to touch on celiac disease. Celiac disease is in the news a lot. A lot of people talk about it. Celiac disease is a genetic disease. You have to have a genetic predisposition for it. And in addition to that, you have these activated genes that then lead to your body recognizing gluten as a foreign compound, right? So when people who have celiac disease, when they eat foods containing gluten, like wheat, barley, rye, as they are digesting that, and that gluten, that gliadin, gets absorbed into the intestine, the body recognizes that as foreign. It has formed antibodies to it, and it attacks that, and it attacks the enterocyte. You can see here, this is an example of those cells of the small intestine. It attacks those cells, and those causes inflammation. And so the microvilli go away, and then even those villi go away, and they get flattened. So in addition to the inflammation, your body loses those villi, and so it can't absorb things as well. And so you get symptoms, again, of abdominal discomfort, diarrhea, and on top of that, you get anemic because you can't absorb the nutrients, specifically iron. People get iron deficient, and they lose a lot of weight, and they can get very sick from that. The treatment for that is avoiding the gluten, so then that inflammation heals, and their GI tract, we can look at it, their cells will return to normal looking, and their villi will return. So that's the basis of celiac disease, and it really disrupts those microvilli and villi. The final disease process I wanted to just introduce here was inflammatory bowel disease. Now, inflammatory bowel disease, or for short, we'll call it IBD. I did want to have a quick caveat. This is not IBS. A lot of people hear about IBS. Dr. Sultan is going to talk a little bit about IBS. That's irritable bowel syndrome. This is inflammatory bowel disease. Inflammatory bowel disease is an autoimmune disease that causes inflammation of the GI tract. And there are two main types. There's ulcerative colitis and there's Crohn's disease. Ulcerative colitis is inflammatory bowel disease that involves the colon and is limited to the colon. It typically involves the rectum, and then, which is the very end of the colon, and then that it can extend back up from the rectum to involve varying degrees of the colon depending on the patient. Crohn's disease can involve anywhere in the GI tract, from the mouth to the anus. It can involve the colon, or it can involve the small intestine. It can even involve the upper GI tract. And this inflammation typically spares the rectum as compared to ulcerative colitis. And in addition, it usually involves the end of the small intestine, or the end of called the terminal ileum. The inflammation in Crohn's disease is typically full thickness, so it involves the whole thickness of the bowel, as opposed to ulcerative colitis, which is typically more mucosal, just the inner surface of the bowel. And because in Crohn's disease, you get that inflammation that goes across the wall, you can end up getting holes in the intestine, like perforations, or fistulas, which are a fancy word for abnormal connections between one part of the body and the other. So that's Crohn's disease and ulcerative colitis. I have another schematic here that it basically just says reaffirms what I already said. In Crohn's disease, typically you spare the rectum and you get patchy inflammation throughout the GI tract. In ulcerative colitis, it typically involves the rectum and then extends in a continuous manner up through the colon. Here we just have some pictures quickly. If you remember here on the left, this is a normal colon. It's nice. It's pink. You can see good blood vessels. You see a good light reflex. And on the right, you have a very angry appearing colon. And this is ulcerative colitis. Those white spots are ulcers, and those red spots are just very red, irritated. You can see there's little spots of microscopic bleeding too. That doesn't look good. And here's a picture of Crohn's disease. On the left, you see a normal small intestine with those normal villi. In the B box, there's some small little ulcers. As you get over into C, the second from the right, you have bigger, deeper ulcers. And then on the far right, you have ulcers that then lead to the stricturing or the narrowing. And that happens in Crohn's disease because you get that full thickness inflammation of the full wall. And over time, that can cause scarring and narrowing. Now, both Crohn's disease and ulcerative colitis can cause very similar symptoms. Sometimes they can differ, but all of these symptoms can work together to cause not only decreased appetite, fatigue, fevers, weight loss, abdominal pain, but they can also cause diarrhea and bloody diarrhea. So I'll kind of echo what Dr. Sloan said about the upper GI tract. If you're experiencing certainly any blood in your stool or bloody diarrhea, then that's something you definitely want to talk to your doctors about because you may want to be evaluated for something going on in your lower GI tract that shouldn't be going. You'll notice here that a lot of these symptoms, specifically the abdominal discomfort, the diarrhea, can be very similar to like the lactose intolerance or the celiac disease, but in neither of those things should you actually have blood in your stool. So blood in your stool is always something that we take seriously, and should be evaluated further. But here we have it. We've introduced the lower GI tract. We've talked about what it's meant to do. We've talked about how it does it. And we talked about some things that could go wrong and cause problems. Thank you for your time.
Great. Thank you, Dr. Howard. So far, between Dr. Sloan and Dr. Howard, hopefully you're starting to appreciate how complex of a system the GI tract or the digestive tract is. He mentioned there too the idea of the pancreas, the liver, also being involved in digestion, absorption of nutrients. We're not going to be getting to those today, but there's a lot going on. So now it's my pleasure to bring in Dr. Shahnaz Sultan. Dr. Sultan is a professor in the Division of Gastroenterology, Hepatology, and Nutrition. There's a theme here. Her research interests are focused on reducing colorectal cancer morbidity and mortality by improving adherence and quality of colonoscopy. Dr. Sultan, can you discuss common gastrointestinal conditions and how gut health connects to systems throughout the body?
Thank you so much, Dr. Teigen. It's a pleasure to be here. I am a general gastroenterologist at the University of Minnesota in the Minneapolis VA. And I'm going to really focus in on the colon because we were saving the best for last. Next slide. I have no conflicts of interest. I do get some research support from a number of different organizations. Next slide. So the objectives of the talk for the next 20 minutes are going to be about why the colon is everyone's business, because we always have to do our business. What do we mean when we talk about disorders of gut-brain interaction? And we'll spend a lot of time talking about colorectal cancer and why we still need to be having conversations about this, especially with some of the newer data we're seeing on early onset colorectal cancer. Next slide. So this is a visual of the colon, just to pick up where Dr. Howard left off. The colon is the last part of the GI tract, and it's broken up into different segments. We label these segments with different titles. So the initial part of the colon is called the cecum. Then we have the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and then finally the anal sphincter and the anus. And the little cartoon depiction of the mucosa highlights again that the mucosa, it does not have villi, it tends to be a flat mucosa, but it has the colon wall has multiple layers. There's the submucosa, there's the muscularis mucosa, there's the longitudinal and the circular muscle walls that help with peristalsis, and then there's the outer coating or the serosa. And the function of the colon is really, as Dr. Howard highlighted, absorption of fluids and electrolytes. But most importantly, it houses our microbiome, which is these trillions and trillions of bacteria that are really, really important for our gut health. They help in vitamin production, so vitamin K, B vitamins, and biotin, and they also help the colon helps in making sure that the indigestible material that is the end result of all of the food that we intake is nicely compacted into stool that is then placed in our rectum and sigmoid as a reservoir until we can actually empty out the colon. Next slide. This is perhaps the most important slide that I want you to take away with because it really highlights this idea of a gut-brain axis. And now we often talk about the gut microbiota brain axis because we know that the microbiome is an important mediator in this axis. So if you look at the top, the brain is always sending out signals to the gut that influence motility, secretion, delivery of nutrients, and also balancing of our microbiome. And the gut is connecting to the brain through hormones, through mechanosensory pathways, through immune mediators, sending signals to our brain through these neurotransmitters that affect our mood, our behavior, stress, anxiety, and then back again. The brain is again taking those neurotransmitters, and then again that influences our gut. So this constant interaction between the brain and the gut is really, really important. The depiction on the right, again, highlights how complex that interplay really is because the highest number of nerve cells outside the brain or the brain and spinal cord are actually inside our gut. So the gut is kind of considered the second brain in some ways. So the enteric nervous system is really, really important in regulating so many different aspects of what functions in our body. And these are mediated through neural pathways, they're mediated through endocrine pathways, they're mediated through immune pathways. And this is why gut health is so important and how it is interrelated to so many other conditions in our body. Next slide. I'm going to hone in on two specific conditions. I highlighted this idea of a disorder of gut-brain interaction. And one of the most common conditions of DGBI is what we call irritable bowel syndrome. And again, making this distinction between inflammatory bowel disease, which is IBD, and irritable bowel syndrome, which is IBS. Patients who have IBS primarily present with symptoms of recurrent abdominal pain associated with some disordered bowel habit or defecatory disturbance that can either be constipation or diarrhea or can cycle between the two and be a mix of both constipation and diarrhea. And the characteristic thing with individuals that have irritable bowel syndrome is that they'll actually, on structural visualization of the colon, have a normal colonoscopy. The lining of the colon will be completely normal, in contrast to what we see in inflammatory bowel disease. And if you do imaging tests, those are also normal, and blood work also is normal. So it's really a diagnosis that for the longest time used to be considered a diagnosis of exclusion, where you excluded conditions until you came up with this as a default condition. But now more and more over the last few decades, that thinking has shifted, and we actually can make a positive diagnosis just based on symptoms alone. And I'll, on the next slide, talk about how we make that diagnosis. if someone has symptoms that could be suspicious for irritable bowel syndrome, often when they see their doctor, there is some minimal testing that we will check for. We'll check for some basic lab work. We might check their thyroid function. We'll want to make sure that they don't have celiac disease. We may check some inflammatory markers or check for some common infections that can present with similar symptoms. But really, more and more, we know that routine stool testing, breath testing, food allergy or food insensitivity testing is really not necessary. And colonoscopy is may be considered in people that have mostly diarrhea predominant symptoms. But apart from just the routine colonoscopy for screening and surveillance considerations after you are of a certain age, and we'll talk about colon cancer screening in a few slides, it's really not a requirement to make the diagnosis of irritable bowel syndrome. Next slide. So this is the criteria that we use for diagnosing irritable bowel syndrome. It's called the Rome 4 criteria. And I don't want you to spend a lot of time going through a lot of the different steps here, but mostly to highlight that this is a chronic condition. You often have to wait for at least 3 months of symptoms to say for sure that this is what the diagnosis is. And then, as I highlighted before, it's really this combination of recurrent abdominal pain or discomfort associated with a change in the frequency and a change in the consistency or form of the stool. And at the very bottom, you'll see that we try to actually categorize patients into one of these 3 categories of either IBS-D or diarrhea predominant, IBS-C or constipation predominant, or IBS-M where you may have mixed stools. And one of the important ways for us to characterize the consistency and form of the stools is through this Bristol stool scale. And you can see this depiction of stool from type 1, where you might have really hard, lumpy pebbles of stool, to type 7, which is really watery stool that may not have any form or consistency to it. And this helps us to understand what are the main types of changes in bowel habits that patients are experiencing. Next slide. So why did I focus on irritable bowel syndrome? Because it's really common. Up to 15% of the US population in the US suffers from IBS. That's a lot of people. 25 to 45 million people will have this diagnosis of IBS in their lifetime. And everyone's IBS experience is really unique. Some people, most people, have very mild IBS symptoms that tend to come and go. Sometimes they'll last a few days to weeks or months, or sometimes they'll be years before they'll have symptoms again. But importantly, symptoms can change over time. And so as we get older, sometimes our symptoms can get more severe. And for a very small subset of individuals, their IBS can be a chronic and debilitating condition. And one of the things we know that can trigger IBS is actually stress. And so when we have someone that we diagnose with IBS, we spend a lot of time with them talking about these triggers and really emphasizing the importance of stress reduction. And this can be through a number of different ways, including meditation, relaxed breathing, as well as even gut-focused cognitive behavior therapy. Next slide. The second thing that we talk a lot about is dietary modifications. We know that fiber is really, really important for the gut. And we often spend a lot of time talking about the importance of increasing fiber in the diet. This is important not only for people that have a condition like IBS, but this is really important for all of us because we don't, in our Western diets, necessarily get enough dietary fiber from what we eat. And so we know that there's different types of fiber. There's soluble and insoluble fiber. And for individuals with IBS-C, we really focus on trying to increase soluble fiber. And that can help with constipation symptoms. And it can also help with ensuring that the lining of the gut is healthy, because we know that fiber is really important as a source of a prebiotic for our microbiome to help in developing, producing short-chain fatty acids and butyrates that are important for our gut barrier function. And then we often advise our patients to also keep a diet food journal and to track if there are specific foods that trigger symptoms and to think about considering avoiding those dietary triggers. Next slide. One of the diets that has been well studied in individuals with irritable bowel syndrome is a low FODMAP diet. And FODMAP is an acronym that stands for fermentable oligomonosaccharides and polyols. And a number of different sources in our diets that contain these different saccharides. And so we often will have individuals meet with a dietitian or a nutritionist where they can kind of talk a little bit more about how to sequentially eliminate some of these diets or to actually follow a full low FODMAP diet, because there's some data to suggest that it does improve overall symptom scores in IBS patients. And there's also some data to suggest that gluten restriction actually provides some benefit in people with IBS diarrhea predominant symptoms, even in the absence of celiac disease. And it's important to know that these foods, they tend to serve as mediators or exacerbators of conditions. So they're not necessarily causing a lot of the symptoms associated with irritable bowel syndrome. Next slide. I'm not going to spend a lot of time talking about all of these individual treatments for IBS-C, but I just wanted to put the slide out there to show that for individuals that have not mild symptoms, but more moderate to severe symptoms, there are a number of different medications that are out there that we can prescribe to help improve symptoms. So improving constipation and improving the consistency of the stool, but also to help with the visceral hypersensitivity or the pain component that is associated with IBS. And these classes of drugs include antispasmodics, they include neuromodulators, as well as different medications that work on some of the different channels and receptors in the gut that control fluid and electrolyte flow into the lumen of the GI system, as well as osmotic laxatives like polyethylene glycol and magnesium oxide. Next slide. And this slide depicts some of the different medications that we use to treat IBS-D or diarrhea predominant IBS, including things like bile acid binding agents and rifaximin, which is a non-absorbed antibiotic, as well as anti-diarrheal agents like loperamide, and then some newer medications that are out there that are specific for the GI system, like elaxadiline, and then as well, again, the antispasmodics, neuromodulators that can help with some of the abdominal pain, discomfort symptoms that also go along with the change in bowel habits. Next slide. Okay, now I want to shift gears and talk about colon cancer. Why do we need to talk about colon cancer? Because it is one of the most common cancers in the US among both men and women. It's the third most common cancer, and it also contributes to colon cancer related mortality. So it is up there as one of the number one causes of death from cancer in the US. Next slide. There's a number of different modifiable and non-modifiable risk factors for colon cancer. So among the modifiable risk factors we often associate with colon cancer are physical activity or lack of physical activity can be associated with a higher risk. Obesity or being overweight, having type 2 diabetes is associated with higher risk, and smoking, heavy alcohol use, as well as a Western diet have all been known to be risk factors for colorectal cancer. And then there are a number of non-modifiable risk factors, like a personal history of inflammatory bowel disease. So individuals that have long-standing ulcerative colitis and Crohn's disease that is not well treated can, over time, have an increased risk over their lifetime of developing colorectal cancer. Individuals that have a personal history of adenomas or colon cancer have a higher risk of developing future colon cancer. And then individuals that have a family history, especially a first-degree relative with colon cancer, diagnosed below the age of 60, are considered higher risk for developing colorectal cancer. And then there are a subset of individuals that have inherited syndromes. The most common are familial adenomatous polyposis or hereditary non-polyposis colon cancer, HNPCC, also referred to as Lynch syndrome. And then there's now more and more data suggesting that Putz-Jaeger syndrome, another inherited syndrome that has mostly hamartomatous polyps, which are a different type of polyp, can also develop adenoma or colorectal cancer in that subset as well. Next slide. if you look at all of the individuals that develop colorectal cancer, the majority of people actually have what we call sporadic cases of colon cancer, meaning they don't have a family history. Only about 10 to 30% of individuals who develop colon cancer actually have a family history of colorectal cancer. And this is really important because this is one of the most common reasons for why sometimes people say they think they don't need to get screened for colon cancer because they say they don't have a family history. But the majority of cancers occur in people without a family history. And only a small subset occur in individuals with these inherited syndromes of Lynch syndrome, FAP, and hamartomatous polyposis syndromes that I mentioned in the earlier slide. Next slide. And we're really fortunate to understand actually how colorectal cancer develops. And some of the earliest research that has been done in colon cancer was done about 20 years ago by these two researchers, Dr. Fearon's and Dr. Vogelstein, and they described this adenoma carcinoma sequence. So adenomas are considered polyps, and carcinoma or adenocarcinoma is colorectal cancer. And by understanding this progression from normal mucosa to hyperproliferation of epithelial cells in the lining of the mucosa, to then these growths that are now called polyps or adenomatous polyps, which initially start out as small, but over long periods of time can grow to become large, to then becoming what we call precancerous polyps that have low-grade to high-grade dysplasia. These are the ones that we know are very close to becoming cancer, to then becoming adenocarcinoma or cancer that then not only is in the lining of the colon, but progresses through the walls of the different layers of the colon wall and then can spread into the body. Next slide. And once we actually have a diagnosis of colorectal cancer, there's also this staging system that we use that helps us to understand the depth of the involvement of the colon wall with this colon cancer. And as I mentioned, early stages that are basically limited to the initial mucosal layer are very easy to resect and actually can lead to 100% cure rates through more and more endoscopic treatments, as well as surgical treatments. But once we start going through the lining of the colon wall and getting to the deeper layers where some of our blood vessels are and our lymphatic system lies, that's where we worry about local or distant spread. And by that time, we're talking about stages T2, T3, and T4 colon cancer, where we still have really good treatments for colon cancer, but the prognosis is not the same. And that's why it's so important to detect cancer at an earlier stage. Next slide. So let's talk a little bit more about polyps, because people always ask, what are polyps and how do they develop? So I mentioned that there's these adenomas, but there are actually other types of kind of categorizations of polyps. Serrated lesions or serrated polyps are kind of the newest pathway of colon cancer development. And we know that adenomas and serrated polyps both can progress to cancer. But we also have these benign polyps in our colons, these hyperplastic polyps that actually do not have any potential or rarely have a potential to become colon cancer. And so if we find hyperplastic polyps on a colonoscopy and we remove them, we don't consider those to give you a higher risk of developing cancer. And we basically think that you're at average risk and don't necessarily need to bring you back any sooner to look at your colon. Next slide. So polyps come in different shapes and sizes and different flavors. And here are some pictures of colon polyps. You see on the left-hand side, there's two distinct polyps for sure, and maybe even a third and a fourth polyp that you see kind of on the right half side of that depiction. This is during a colonoscopy where we're looking at the inside of the colon. And then you see on the right side a polyp that has a bit more distinct features, where you can see that there's a little bit more redness and a little bit more of a defined structure to the polyp that looks like it's a bit more raised, protruding into the lumen. Next slide. Some polyps can be really, really flat. These are these sessile serrated polyps that I mentioned earlier that tend to be very indistinct. have very subtle findings, and can be very, very easy to miss. And this is why one of the things, most important things we stress when undergoing a colonoscopy is that the prep is really, really important, because as you can imagine, we want to be able to detect these polyps and make sure that we have a really good, clean view of the lining of the colon. Next slide. And this is colon cancer. When these polyps over time, we think that time period is anywhere from 5 to 15 years, stay inside the colon, they have the potential to develop more mutations and to continue to proliferate and grow. And as they grow, they can develop dysplasia and then become carcinoma. And you can see that the cancer on the left-hand side is really big and bulky and protruding into the lumen. And then you can see on the right side that this cancer is actually encroaching into the lumen, so much so that there's actually even a narrowing and potentially could lead to a blockage because of this cancer. Next slide. So one of the most important things that we do to prevent colon cancer is we detect and we remove polyps. And this is a depiction of, again, the colon, and how when we go in with our colonoscope, our goal is to really traverse the entire distance of the colon to get to the cecum. And then as we withdraw from the colon, we're actually looking at the lining of the colon and examining the colon wall so that we can look for these polyps, because if we detect them, we can resect them. Next slide. And this is one of the ways that we resect polyps. So you see here, again, this is a colonoscopic view of the colon. You'll see the rim, there's what we call a clear cap, and that clear cap sometimes helps us with better detection of polyps. We can actually, through that cap, visualize behind folds much more readily. And there's a polyp you see in the center of the screen, and through the sequential steps, you're seeing this white probe that's coming out with what looks like a diamond-shaped wire associated with it. That's called a cold snare, and we're actually able to open and close that snare. You can see that we close that snare onto that polyp, and we basically snip it off. A very superficial layer of the mucosa comes off, and that's how we actually remove the polyp, and which you see on the bottom kind of right part of the slide. And that's called a polypectomy. And by removing that polyp, we send it to pathology lab. We look at it under the microscope, confirm what kind of polyp it is. And this is one of the best ways that we can prevent this polyp from staying inside the colon and growing into cancer. Next slide. So there's a lot of interest in colonoscopy, and there's a lot of efforts to actually promote colonoscopy uptake. You see a lot of celebrities posting these days on different social media platforms about their experience with colonoscopy as a way to demystify the process, as a way to kind of really motivate people to undergo their colonoscopy. If you ever have any spare time and you go down looking at these reels, you can really go down a rabbit hole. There's a lot of interesting, funny anecdotes and stuff out there. Next slide. So we've been doing colonoscopies now for over 2 decades, and I talked about how it's one of the most important ways to prevent colon cancer incidence and mortality, but this is actually data that is published. This is from the American Cancer Society, that shows that over the last few years, we're actually seeing a decline in colon cancer-related mortality. And this is because of population-based screening that was initiated around in the 1990s now to over the last 2-3 decades. And you'll see that there's a peak and a decline with stool-based testing that was initiated. That's what FOBT stands for, fecal occult blood testing, and flexible sigmoidoscopy. And then another peak and decline with colonoscopy, which was really introduced at a population-based level in the 2000s as a way to screen for colorectal cancer. Next slide. And this decline also coincides with increasing uptake of screening. So early on, rates of colon cancer screening were about in the 30-40%, and now nationally, we're up to about 70% of the US population is up to date with colon cancer screening. But we'll come back to this because there are huge disparities in who gets screened and who doesn't get screened. Next slide. If you look at the United States Preventive Services Task Force, which is one of the most important organizations that helps make coverage decisions for colon cancer screening, they recommend a number of different tests that you can perform, or all at very different intervals. So colonoscopy for colon cancer screening every 10 years if it's negative, stool tests, fecal immunochemical test, as well as the kind of prior older fecal occult blood test that I alluded to earlier, that should be repeated every 1 year if it's negative. And then you have your stool DNA test or your Cologuard test, which should be repeated every 3 years if negative. And then your flexible sigmoidoscopy, which basically looks at only about a third to a half of the colon, and a CT colonography, which is like an imaging test of the colon that is repeated every 5 years if negative. Next slide. But really, the three most common tests that are really currently endorsed and utilized in the United States are colonoscopy, fecal immunochemical test, and stool DNA tests. So these are the three most common tests that are currently being used. Having said that, despite having the option of doing a colonoscopy, which is invasive, or a stool test, which is non-invasive, there are still populations of individuals that just don't undergo colon cancer screening. And with that in mind, there's been a lot of research to try to develop newer tests, newer stool-based tests, and even blood-based tests to screen as a way to increase uptake. Next slide. And there's two new stool DNA tests that are out on the market. There's the Cologuard Plus and there's the ColoSense. And these, similarly as the Cologuard test, the way these tests work is that they not only look for microscopic amounts of blood in the stool, which this blood we think is there because these polyps tend to be very, very easily irritated by passage of stool and water. So small amounts of blood can actually be shed in the stool, and the FIT test and the old fecal occult blood test, as well as the Cologuard test and these newer tests, all detect these microscopic amounts of blood that you can't see in your stool. But in addition, they also look for changes in the DNA or the RNA of the cells that are shed from these polyps. So these polyps have these mutations that are not normally present in the normal cells of your colon. And when these cells turn over and they're shed in the stool, these mutations can be detected with these different tests. So these are the newer tests that are out on the market, and they're FDA approved, but they're still awaiting the recommendation of the United States Preventive Services Task Force, so they're not necessarily yet covered by insurance. Next slide. These are the two blood-based tests called the Shield test and the Simple Sense test. And this is really just a blood test where they take blood from your body. And what they're looking for are these circulating free DNA in the bloodstream, so that those same mutated cells or those same fragments of DNA that we're looking for in the stool, they're looking to see if they're in the bloodstream as well. And these can be detected in the blood. One of these two blood-based tests has been FDA approved. The other one has not actually been submitted for FDA approval yet. And again, they're not at the moment endorsed by the United States Preventive Services Task Force, so may not be covered by insurance. Next slide. So how well do these perform? Well, this is a busy slide, but just to highlight that these new stool tests work just as well as some of the older tests, and a little bit better. So they're a little bit higher in specificity, which is good. So actually, these tests seem to be performing at a slightly a better level than the existing stool test that we have. Next slide. But when you look at the blood-based tests, they perform a little bit worse in terms of sensitivity and specificity, and we'll talk about that a little bit more on the next slide. So if you think about these blood-based tests and what they're focused on detecting, they're really detecting cancers or advanced polyps, which are those bigger polyps that are very close to becoming cancer that I highlighted when we looked at the sequential progression from polyp to cancer. And you'll see that even at this stage of detecting cancer, They're pretty good at detecting stage 2 cancers. So if you look at the bottom, 100% for stage 2 cancer, but not so good for stage 1 cancer. And remember, I mentioned that stage 1 cancer is the cancer that has the best prognosis in terms of survival because it's the early stage cancer that has not yet progressed into the deeper layers of the colon wall and into the bloodstream. Next slide. So low sensitivity for these advanced polyps, as low as 13%. Next slide. And it failed to detect 45% of the stage 1 cancers. So all this to say that at the end of the day, these blood-based tests are a step forward, but we're unsure yet whether they will get approval, and perhaps there may or may not be a role for them, but certainly there's opportunities for further development and improvement in terms of the performance. Next slide. The most important thing to remember with any of these tests that are non-colonoscopy based, any stool test that's positive, any blood-based test that's positive, means you need to get the colonoscopy, because the colonoscopy not only allows you to detect those polyps, but it allows you to remove those polyps, do that polypectomy that actually is the most important thing for preventing colon cancer. Next slide. So I wanted to talk about early onset colorectal cancer because this is really something that has been in the news quite a bit. And there's been a lot of conversation being had about this because it is really alarming that we're seeing colon cancer in young people for the first time that we never saw 20, 30, 40 years ago. And many of the individuals that are diagnosed with early onset colorectal cancer are actually diagnosed once they have symptoms, often blood in the stool or anemia or symptoms like change in bowel habits, and they're often diagnosed at advanced stages, so stage 2 or stage 3, and so they have a worse prognosis. Next slide. A lot of research is being done to understand why we're seeing this early onset colorectal cancer, but we are starting to consider this or frame this as a birth cohort effect. And we think that it's something that is being seen in individuals that were born 1960 and later. We're seeing an increase incidence of cancers, and we're also seeing a little bit of a shift in the types of cancers that we're seeing. And there's a lot of work. Once we start thinking about this as a birth cohort effect, a lot of focus on some environmental factors that could be contributing. And there's research being done looking at metabolic disorders, trying to understand if there are changes in our diet and lifestyles that are playing a role. Are there early life exposures that are contributing? There's work focused on ultra-processed foods. There's work focused on microplastics in the environment. All of these could potentially modulate the gut microbiome, and perhaps these are all factors that are contributing or explanations for some of these early onset colon cancers that we're seeing. But we're still in the early phases of trying to fully understand this. Next slide. So I talked about rates of colon cancer screening being nationally at the 70% range, and certainly in the state of Minnesota, 70% of individuals are up to date with colon cancer screening. But when you start looking at the breakdown of cancer screening rates by language or by country of origin, you start to see rates as low as 34% or 32%. So there's lots of opportunities for improvement in terms of increasing colon cancer screening rates, even in our own state of Minnesota. Next slide. And this is some of the work that I do. Most recently, we've been working with our mobile health initiative to actually increase rates of colon cancer screening in the communities, and largely through community partnerships with organizations like Popley, People of Power Leadership Institute, Wellness Village, Turning Point, Ayana, Islamic Association of North America, Sabatani Community Center, and the Hmong Medical Association as organizations that are trying to promote colon cancer awareness and allow for us to partner with them to bring this message to these communities, highlighting the importance of colon cancer screening. Next slide. This is actually my second to last slide. I just wanted to highlight that this is ongoing work we're doing through the MCAMP Mobile Cancer Assessment Program. There's a link to or information about this program on the Masonic Cancer Center website. And next slide, I'll end with a little bit of GI humor, which I'll let you kind of take in.
All right.
And
Thank you,
that's
Dr. Sultan, and for the humor here to end it.
Thank you.
Thank you again to all of our panelists. We will now move on to the questions submitted by our attendees, or at least some of the questions. As a reminder, you can still submit your questions to our panelists using the Q&A box, which can be found by clicking on the Q&A box at the bottom of your Zoom screen. All right, so first question, we'll go back to the beginning, and we will start with Dr. Sloan. And so there's kind of a theme of aging here, so it's going to be kind of a two-part question. So the first part is what's happening when you swallow a large pill and it feels like it gets stuck. And then we're going to wrap that into as well, how does aging affect the ability of the esophagus to swallow effectively, or does it?
Yeah, good question. So, with respect to large pills and what's happening, that's actually a really complicated question, right? Because it could be a number of different things. It could be a specific pill, right? Some pills are known to get caught in the esophagus a little bit more frequently. Other reasons for having a pill get stuck, or at least getting the sensation that it's getting stuck, again, could be, is there vertebral body compression on the esophagus, right? So your spine pushing against the esophagus. You could have a motility finding or a motility abnormality that's contributing. There could be underlying reflux. There could and erosive esophagitis, again, causing things to slow down. It could be an oropharyngeal process, right? So again, thinking about that initiation of the swallow and the muscle function there. And with respect to, the reasons go on. I think the important thing to kind of sum that up is if you're having dysphagia, even if it's just pill dysphagia, bring that up to your provider. Because it's one, you shouldn't have dysphagia, and we should kind of explore with endoscopy to try to understand what that etaology is. And subsequently, perhaps a manometry, right? Which then wraps into, okay, so what about aging in the esophagus? A lot of times you'll see comments about presbyesophagus or old esophagus. I don't just because one is aging doesn't mean that your esophagus isn't going to work. There are plenty of people as we age. In fact, the majority of people who have normal motility through aging. So it's not a definite that one will have difficulty swallowing as they age.
Great, thank you. Next question will be for Dr. Howard. I think parallels well off of Dr. Sloan's here. So in addition to what he was talking about with the swallowing and bringing that up with your PCP, we've talked about a lot of different stuff here. So what kind of workup do you want to be doing with your primary care prior to a GI referral? When should you be asking for a GI referral?
Yeah, I mean, that's always a good question. I think it really depends on the symptoms you're having. I think definitely if there's concerning symptoms, bring them up with your primary care doctor. They're well versed in when to refer to the GI team. So, if we're talking more lower GI tract stuff, the biggest thing is, like we talked about, alarm, or Dr. Sloan mentioned, and I think I mentioned alarm symptoms. Lots of people can have IBS symptoms. They're very common, 15% of the population. Change in bowel habits, abdominal discomfort. Your doctors can definitely talk to you about that, and they can help see if they think something like irritable bowel syndrome is at play. However, if you're having blood in your stool, if you're having weight loss, if you're having trouble swallowing, if you're having, stooling at night that's waking you up from sleep. These are things that usually are that we call alarm symptoms, and they warrant further evaluation, and often referring to the GI team, where we may consider, do you need an upper endoscopy? Do you need a colonoscopy? Do you need some other further imaging? And having the alarm symptoms is really when you want to refer for more specialist care. But again, talk about your symptoms with your primary care. They'll help guide you as well.
Great, thank you. There's another question that I'm going to endeavor to answer, and then if any of you have any additional comments. So there's a question, let me find it here, about sparkling water, diet sodas, their impact on gut health. So I would say the short answer is that we don't really have a great answer for that. Just in general, like the carbonation can contribute to some of the symptoms like acid reflux, like Dr. Sloan was talking about, can contribute to some of the IBS symptoms like Dr. Sultan was talking about. As it relates to the diet sodas, maybe some of the artificial sweeteners can somehow interact with the microbiome. But at this point, it's not clear that other than a symptomatic effect, that there's any impact, specific impact of sparkling water or diet sodas on gut health. Anything additional from any of you? Otherwise, I'm gonna move on to another question.
I mean, I think just to piggyback on that, and you touched on it, but if you think about it, right, if you're ingesting something that's carbonated, there's going to be gas that you're bringing in with that drink, right? So if one of the symptoms that you're experiencing is belching, well, maybe cutting back on a carbonated beverage is probably going to improve that symptom. Other things like bloating, abdominal discomfort, again, from that gaseous distension, you kind of have to think about what you're putting in and how that might relate to those symptoms.
All right, thank you. All right, so then for Dr. Sultan, you were talking about the IBS space. Can you speak a little bit about, someone's asking about SIBO, and what that is and maybe potential causes, treatments?
Yep, and I would love to also hear Dr. Howard's input on this. So SIBO stands for small intestinal bacterial overgrowth, and it's a diagnosis that we make often in people who present with abdominal bloating, feeling of distension, feeling of fullness, feeling of gassiness. And there are tests that we can perform for it, as well as treatments. And one of the treatments is actually one of the recommended treatments for irritable bowel syndrome, which is rifaximin. But I'll actually defer to Dr. Howard to expand on that.
Yeah, this is a really good question, and again, SIBO is one of the hot topics, like celiac, in medicine right now. But like Dr. Sultan said, small intestinal bacterial overgrowth. So if you remember when we talked about the small intestine and the large intestine, the small intestine is mostly without a lot of bacteria. Now there's not no bacteria in there, but there's fewer bacteria. When you get to the colon, that's where most, thousands plus of bacteria are. And if you remember, like what we talked about with lactose intolerance, there's a lot of overlap between lactose intolerance and SIBO. They have a very similar concept. In lactose intolerance, remember, if you are able to break down the sugars and absorb them, things go very well. Those sugars don't get down to the colon where the bacteria are. The bacteria can't digest them and cause the gas and the diarrhea. And if you have lactose intolerance, those sugars go down there and go to the colon and cause problems. Well, if you take those bacteria from the colon and move them up into the small intestine, which is what happens in small intestinal bacterial overgrowth, those bacteria, even if the small intestine is working appropriately, those bacteria can get to those sugars before the small intestine's done with them. And those bacteria chomp down on those sugars, produce that gas, produce those other acids that cause the symptoms. So that's why it causes that gas and bloating. Now, there's different ways to treat that. Well, first you can detect it by doing a breath test. And the long and short of it is that you take in some sugar, wait a certain amount of time, blow into the sensor, and if there's increased hydrogen and methane where there shouldn't be, that's consistent with small intestinal bacterial overgrowth. Now, you can take antibiotics that will kill those bacteria off, and that can cause improved symptoms. Some people feel better for a long time, never have more issues again. Other people may feel better for a short period of time. Another thing we can do is we can work with, like Dr. Teigen, our nutritionists, dietitians, because if you decrease the sugar that people are exposed to, if you do like a low FODMAP diet, which is these certain sugars, if you minimize those sugars that you eat, then you decrease those sugars being presented to the bacteria in the small intestine, and so they don't cause those symptoms.
Great, thank you. All right, well, so thank you to our panelists today for your time and for sharing your insights into why maintaining gut health is essential for overall well-being. I really liked all of your slides, but there was one slide in particular, I think by Dr. Sultan, that showed the nerve innervation with the GI tract, just really sending home the point of just how intimately the gut is tied to the rest of our overall health. So thank you to all of you, and our thank you too as well to the participants in this mini medical school, and for joining us today. We hope to see you next week for the second mini medical school session on the role of probiotics and nutrition. We'll be at the same time next Wednesday. We'll speak with an amazing group of experts. We'll dive into the world of the microbiome and its relationship to diet, probiotic, and supplements. Thank you and have a good evening.